Now it gives me great pleasure to introduce Dr. David McCarty, who's going to talk about sleep in the ICU. I don't know, if you're not involved intimately with ICU, you may not realize this, but this has become a very important, very hot topic recently. When it's been realized that sleep disorders and issues with sleep are probably one of the underlying causes of the ICU delirium that we see. We try to address this, we're oftentimes not very successful. And as I told David, most of us don't understand the basic physiology of sleep anyway, at least I don't. So I think this should be very informative and something right on the edge of where we're going in critical care these days. David?
Great. Thanks. First of all, thanks to Dr. Weigel for inviting me to come talk to you. If any of you have ever met me, I'm a self-described sleep geek. I love sleep. I love what it does for you, and so hopefully we'll have some fun today and we'll learn something too. Let's see if I can get this thing to work. I don't have any disclosures. My goals for today, I want you guys to be able to intelligently discuss physiologic changes that occur during sleep and the mechanisms involved, to talk about what can happen that's bad if you get sleep deprived. I have a 5-finger approach that I use to teach my fellows how to unravel a complex problem like sleep disruption, and I'm going to teach that to you because it applies to the ICU as well. And then I'm going to try and leave you with some practical strategies that might help minimize the impact of sources of sleep disruption. And I want to make a very important disclaimer, and that is that this is not going to be about delirium and it's not going to be about sedation. Those are whole topics in and of themselves, and you all know a heck of a lot more about those things than I do, but it does overlap into those fields. And so I'm going to try and stay focused on my little edge of the forest, which is sleep. So why should we have this talk? Well, sleep is vital to normal physiology. We need to do it. And ICU patients are often sleep deprived during their care in the unit. And the first step towards making any changes is just to recognize the problem. We can only talk about what we know about. We only see what we know. So this is going to be an introduction to perhaps some new concepts. The ICU, as all of you well know, is a team, and there are lots of components of the team. So having everyone on board is going to be important to implement any changes. Here's how I'm going to approach it. I'm going to introduce you to the basic structure and mechanisms and physiologic changes of sleep. Dr. Weigel says this is something that maybe some of you haven't been introduced to, so I'm going to give you some of the vocabulary that I use when talking about sleep. I'm going to introduce what sleep deprivation can do to you that's bad, my 5-finger approach, and my specific sources of sleep disruption in the ICU using that approach, and then finally some practical strategies. So first of all, so we're on the same page, it's not a foregone conclusion that everyone knows exactly what sleep is. So what is it? It's a reversible behavioral state of perceptual disengagement from and unresponsiveness to the environment. It's typically accompanied by postural recumbence, behavioral quiescence, and closed eyes. So now we understand what it is. I want to introduce this idea, and that there's been a change in how we perceive sleep, some of which has been perpetuated by us. So let me take you back a few hundred years. Here is a statement about sleep. Enjoy the honey-heavy dew of slumber. Anybody know who wrote that? Going once. I'm trying to wake you up now. Shakespeare. Yeah. My buddy, Bill. And it's Julius Caesar. Now here's another quote about sleep, a little more recent. Sleep is a criminal waste of time, inherited from our cave days. Who said that? You're attending on SICU rounds? Thomas Edison, look at that grump. Now, it probably won't, it comes as a bit of a surprise that William Shakespeare died at age 52. Thomas Edison lived to the ripe old age of 84, so maybe this blows my whole hypothesis out of the water. But it also shouldn't come as a surprise that Thomas Edison invented that, which is my chief foe when trying to get people to sleep at night, and is also one of the sources of sleep disruption in the ICU. Anybody know who that guy is? Surgeons? That's Dr. Halsted. And Dr. Halsted made a career out of being attentive and assiduous with his details. And he did it with the help of two very important partners. And I'm not talking about Welch and Osler. I'm talking about this one and this one, which is cocaine and morphine. So he was a substance user, and perhaps he more than others drove home this idea that, you know, sleep may be optional, and sleep is for the weak. And perhaps this is part of our culture that we need to rethink. So why do we do this? Why is this something that's so evolutionarily conserved between species? Well, there's the idea that somehow it's involved in restoration, energy conservation, and brain processing. And the types of brain processing that are assisted with sleep include memory consolidation, the ability to perform complex problem solving, and also system responsiveness. There are some people who believe that rapid eye movement sleep and dreams is sort of like an emergency response system that allows you to deal with emergencies even if you don't deal with emergencies in everyday life. So here's one big concept that I want to leave you with. Why does sleep do what it does? Well, it turns out the way we think about sleep these days is it has a two-process model. The first process is process S, and the second process is process C, and I'm going to discuss what these mean. So rule number one, being alive, awake, and metabolically active makes a person sleepy in proportion to the amount of time that you've done that. And this leads to this idea of sleep pressure. The longer you're awake and doing active things like this woman here, the more sleep pressure you build up over time. Rule number two, the brain, however, is wired to allow you to stabilize your wakefulness despite the fact that this sleep pressure is building up over the course of the day. And rule number three, there is an optimum opportunity that's on this clock, and this is called our circadian sleep phase, and it allows a scheduled downtime of wake-promoting centers in the brain, and it's concomitant with a scheduled sleep promotion area in the brain as well. And so this is known as the process C. So another way to think about the two-process model is in this cartoon. You can see here during wakefulness, the more you're awake, the more sleep pressure builds up, and then sleeping takes away that sleep pressure. Process C is subserved by areas in the brain, and you can see that as sleep pressure builds, this has to counterbalance that sleep pressure to maintain a stability of alertness, and then things kind of shut down on a timer and allow that sleep pressure to work its magic. So the best sleep happens when you've got a maximized amount of sleep pressure at the time when your alertness centers decide to shut down. Okay? So another way to look at this, during the course of the day, you go from being not sleepy to sleepy. Your brain fills up with stuff that supposedly promotes sleep. That's called sleep pressure. So you have to wonder, does this guy over here on the left, is that guy going to have as much sleep pressure if he's kind of sleeping on and off? How is that going to lead to nocturnal sleep consolidation? And what if you're the folks running the team? You ever wonder why you crash and sleep so heavily after a long day at work? Maybe this has something to do with it. So how does sleep pressure work? This part, when I first learned this, I found this fascinating. Sleep pressure is actually measurable, and there are certain substances that can build up in the brain that are byproducts of metabolism. And the best studied of these is adenosine, which is a breakdown product of ATP. That's what it looks like. And it just so happens that this is why caffeine tends to work to keep you awake, is that caffeine tends to block the receptors in the brain that adenosine can stimulate. Other elements include IL-6, IL-1, TNF-alpha, prostaglandin D2. For those of you interested in immunology, these are part of that system, that cascade, and they're metabolic byproducts. The more of this builds up, the more sleepy you get, and then sleep clears these things. Now, process C is a different matter. This is not a global bathing in sleep-regulating substances. These are areas of the brain that are involved in wake promotion. So this whole system is called the ascending reticular activating system. We learned about this in medical school. And there are lots of different elements. So it's a redundant system and lots of different neurotransmitters, including histamine, hypocretin, dopamine, acetylcholine, and norepinephrine. During sleep, there is an area of the brain that is actually sleep active, and it's right there. It's called the ventrolateral preoptic area, and this, as you can see, is connected to a lot of these elements of the ascending reticular activating system, and sends them inhibitory signals via galanin and GABA. Melatonin is a very misunderstood substance when it comes to sleep. It's kind of marketed as a supplement that is a sleeping pill, but it's a lot more complicated than that. So it turns out that melatonin release is controlled by our biological master clock, which is the suprachiasmatic nucleus. There is a noradrenergic synapse in the superior cervical ganglion that leads directly to the pineal gland, which is there, and that allows for melatonin secretion. Now, what's interesting about the fact that it's noradrenergic is that beta blockers can suppress melatonin secretion, and it's thought to be one of the mechanisms by which beta blockers can cause insomnia. Now, release of melatonin is stimulated by darkness and inhibited by light. I explain this to my patients by telling them that melatonin is kind of a shy hormone. It doesn't come out when it's bright outside. It's only coming out when it's dark. But we can use this fact to figure out where a person's sleep phase might be. Because if you keep someone in dim light surroundings, there will be a moment when suddenly in dim light, melatonin secretion starts to take a turn upwards. And that's called the dim light melatonin onset. And it's a good, reliable marker for the patient's circadian sleep phase. Now this concept is a wild map here, and this is central to understanding how sleep works with respect to melatonin and light. So this graph is called a phase response curve, and the point of this is that melatonin and light don't work the same way on the circadian sleep phase at all times of the day. So unlike a medicine like Ambien, for example, if I give Ambien to you at 2 o'clock in the afternoon, it's going to have a CNS inhibitory effect just the same way it would if I gave it to you at 10 o'clock at night. So it works the same, it has the same biological activity. If I give you melatonin, if I give you melatonin since my poker here, if I give you melatonin at 4 o'clock in the afternoon, what it does to your circadian timing is it advances it. However, if I give you melatonin after this crossover point here, which is about 3 hours after the dim light melatonin onset, it will cause a delay to your sleep phase. Oh, heavens to Betsy. Here we go. Light functions in kind of a mirror image to melatonin in that light phase response curve tends to cause a sleep phase delay when you give it at night, but after the core body temperature minimum, it causes a sleep phase advance. And here's a picture of what happens when you expose a person to light at different times of the day. If this is my light pulse, and this is successive days of sleep time, and this is a cartoon, but in each of these, you can see that the timing of sleep is a little bit later each time. The closer I get this light pulse to this acrophase of the delaying, or the nadir of the delaying forces, you can see the more of a delay we'll have on the subsequent day. If you move it later in the night, it makes the successive day sleep onset earlier. Okay, so where you expose the patient to light is going to have a huge bearing on what it does to their circadian rhythm. This chart is to remind us that even though we have been accustomed to a 24-hour day, our innate circadian rhythm is actually longer than 24 hours. If you take somebody and put them in an entrained environment where they're getting proper light-dark signals, their sleep phase will stay the same, and the sleep on this one is denoted by the dark bars. But if you put the person in a completely Q-deficient environment, meaning there is no light pulses that are going to entrain them, their circadian rhythm will become free-running, and each successive sleep onset on each day will be delayed by a matter of minutes, so that after about 35 days, you'll actually advance their sleep phase all around the clock. So what happens during sleep to physiology? Well, thermoregulation changes for one thing. The core body temperature minimum, core body temperature tends to peak late in the day, and it's going to start declining before sleep onset. And during REM sleep, we actually become poikilotherms, meaning we have loss of compensatory responses. We don't shiver. We don't generate heat. And our core body temperature minimum happens about 2 to 3 hours prior to the usual rise time. Respiration changes. We no longer have voluntary control. It all goes on automatic pilot. And the responses to respiratory stressors like hypercarbia and hypoxia are actually blunted. This chart reminds us of all the things that can happen during sleep, and it varies by sleep stage. So the point of this is that REM sleep tends to be the most blunted in terms of responses to hypercarbia and hypoxia. So what else can happen? During during non-REM sleep, there is relative cardiovascular stability. So the blood pressure tends to be stable, heart rate and systemic vascular resistance are stable, and we will see a respiraphasic heart rate variability that has to do with the vagolytic effects of inspiration. REM sleep has more autonomic variability. So we have something known as phasic REM and tonic REM, and has to do with when the eye movements happen and when motor activity might be seen. And during tonic REM, we see a lot more vagal activity, which can actually lead to bradyarrhythmias. During phasic REM, we'll have bursts of sympathetic tone, and those are accompanied by elevated heart rate and blood pressure. In terms of GI physiology, esophageal motility is reduced. Rectal tone, however, is preserved. GI motility overall is unchanged, but swallowing and saliva production are decreased. There is an increased tone of upper esophageal sphincter that tends to be a protective mechanism against aspiration, and gastric acid is increased actually in early sleep. In terms of the endocrine system, during sleep there is a growth hormone and prolactin peak. This is suppressed with sleep deprivation. Cortisol tends to decrease and then has a rise during the early morning hours. And TSH is going to peak right before sleep onset and declines during sleep. So sleep is suppressive of TSH. And what's interesting about that is if you sleep deprive someone, the TSH will actually go up. And this may explain why we have the so-called sick euthyroid syndrome, where someone gets ill and is in the hospital and you check their TSH and it's elevated, but when they get well, it goes back to normal. All right, so a lot of folks are familiar with the concept that sleep is generally categorized into stages. We stage sleep. We've invented this based on what we've seen by what we're able to measure. And so it turns out it's based on pattern recognition, and we think we've found different flavors of brain activity that we can then separate into stages. So to do this, we use 3 sources of information. We use the EEG, we use the chin EMG, it's a surface EMG, that gives us an idea of underlying motor tone, and we use the electrooculogram, which measures eye movements. And during a sleep study, we separate each 30-second interval into pages we call epochs, and we assign it to one of 5 mutually exclusive stages. It's either going to be wake, N1, N2, N3, or R for REM sleep. And just to give you an idea of what normal is, and what the heck is normal anyway, but normal for an adult, we're looking at a stage distribution of about a quarter of the night in REM, about half the night in N2 sleep, about a quarter of the night in N3, and very little sleep in N1, which is kind of a transitional stage of sleep. So the EEG, remember the EEG is a collective interpretation of the behavior of millions of cortical neurons as measured at the scalp, and the varieties of synchronization arise out of interactions between the cortex and the thalamus. What we see during wakefulness is typically a high frequency, low amplitude, very complex and chaotic waveform. During non-REM sleep, the waveform becomes slower and progressively more non-random. It gets to be more predictable. So non-REM sleep we can stage just looking at the EEG. Now REM sleep is a completely different animal. The old name when we were studying animals for REM sleep is paradoxical sleep, and the reason for that is it's paradoxically very active brain behavior. It resembles stage wake, as a matter of fact. It has a high frequency, low amplitude waveform, and therefore to stage REM, we actually have to look at other data sources. We have to look at the chin EMG, which tends to drop. Remember, REM sleep is associated with paralysis of all the skeletal muscles, except for the eyes and the diaphragm, of course, because it helps you breathe, but everything else goes atonic. So we look for atonia in the chin, and we watch the eyes. And if there are eye movements that are typical for REM, then that's also a clue for REM sleep. This is an example of a so-called normal hypnogram. This was actually made when we were still separating N3 into stage 3 and stage 4 sleep. We now don't think there's a physiologic difference, so we just group them all together as slow wave sleep. But this is kind of how it goes. You go from wakefulness briefly through N1, you'll do some slow wave sleep, which is heavily weighted towards the front of the night. That's where sleep pressure lives. And then you'll go through progressively longer REM cycles at approximately 90-minute intervals. This is a typical choreographed dance that we all go through unless something goes wrong. So what happens if we don't get proper sleep? I think we've all been there. We know that we don't feel good, but what do we know about it? Well, obviously the mood can change. We can have irritability, difficulty concentrating. Anybody who's been post-call could tell you that. In the setting of long-term total sleep deprivation, these psychological changes can actually progress to perceptual distortions, paranoia, and frank psychosis. Sleep deprivation causes an elevation in evening cortisol, the stress hormone. There is increased overall sympathetic tone. There is decreased thyrotropin activity, decreased glucose tolerance, elevated CRP, and we know from epidemiologic data that long-term exposure to short sleep intervals elevates the long-term risk of cardiovascular events. So from the Nurses' Health Study, those who slept less than 7 hours a night for a long-term basis were more likely to die of heart attacks, for example. Sleep deprivation may have deleterious effects on the immune system. So this was an experimental study with an experimental inoculation of a standard rhinoviral infection, and those who slept less than 7 hours a night were much more likely to get the disease than those who slept in a more standard 8 straight type of schedule. When we look at markers of inflammation, you might remember that nuclear factor kappa B is a kind of a puppet master of other inflammatory responses. So it's considered to be a controller of systemic inflammation. And PSD here stands for partial sleep deprivation, and this is just an example of what partial sleep deprivation can do to the inflammatory response. You can see there's an elevation in nuclear factor kappa B, and then during recovery it comes back down. There is a bidirectional relationship between sleep and pain. As doctors, we should care about this. Turns out that sleep deprivation alters the CNS serotonin handling and endogenous opioid mechanisms, and sleep loss actually can increase a patient's sensitivity to pain and their subjective sense of suffering. Therefore, increased pain can turn back around, and we all know that pain can disrupt sleep, and this leads to the pain-sleep vicious cycle. This is an interesting experimental study, and for those of you who do shift work, you'll find this particularly compelling. This was done on I think it was mice or rats. It was a murine model of some kind. And what they did is they subjected these animals to frequent sleep stage shifts, simulating shift work changes. And they found that it was much more difficult on the animals to advance their sleep phase than to delay it. This goes along with what we understand about biology. Remember our 25-hour cycle in a 24-hour world. Our tendency is to want to delay our sleep phase every day. It's much easier for us to do that. It's much more work on our internal biological clock to try and advance it. So when you take an animal and you put them on a frequent phase advancing schedule, what we find is that they die more frequently. These are the animals that were on that schedule, and their survival rate was much lower. Here's some more general truths about sleep. We enter sleep through non-REM. Non-REM and REM alternate with a period of about 90 minutes. We'll get most of our slow wave sleep at the beginning of the night, because that is something that's powered by all that sleep pressure we've built up. And REM predominates in the last third of the night. So REM is one of those things that's also on that circadian timer. The REM sleep peaks at the core body temperature minimum, which is about 2 to 3 hours before your standard usual wake time. So here's where this comes into direct contact with y'all. We know that most ICU patients experience both sleep deprivation and delirium. We know that elderly, previously demented, and mechanically ventilated folks are most at risk for delirium. We know that delirium is independently associated with mortality, increased cost and length of stay, and also with, unfortunately, long-term cognitive impairment after discharge. Now here's what we don't have our hands around yet. Whether ICU sleep deprivation contributes to this hasn't been definitively established. We think it does because of all the things we know about sleep deprivation not in the ICU, because they share important mechanisms and risk factors. But what we think is the next step in terms of how to manage delirium is how to deal with the sleep disturbances inherent to the ICU. So now we're getting to the real meat of this talk. There are some real challenges to studying sleep in the ICU. The standard way to measure sleep, as I was telling you earlier, has a multi-channel approach. It's called a polysomnogram. It involves EEG leads to get staging and all kinds of stuff. It's expensive and it's cumbersome, and it's also fraught with potential confounders because patients who are critically ill, they become encephalopathic and their brain waves change, and it's very difficult to sort these things out into the stages that we think we understand. One of the things that we can try is subjective survey instruments. One of the most widely used is something called the Richards-Campbell Sleep Questionnaire. This is nothing more than a 5-question survey with visual analog scales to rate the perceived sleep depth, efficiency, and quality. So you kind of get to the meat of the matter, and assuming you have a patient that's reliable, you can speak with them and ask them how they slept, did you sleep deeply, etc. For patients who are more moribund or perhaps less responsive, there are validated proxy measures of this survey as well. And this just underscores the point of why this could be important. These stripes here are not the medals on a general's chest. These are fragments of sleep over a 24-hour period. So in this series, 5 patients underwent 24-hour polysomnography to document when they were sleeping. And the point here is that you can see it's just this one's scattered kind of sleep, wake, all throughout the 24-hour cycle. This is not something that you can just measure sleep at night. We need to have some way of measuring it throughout the day, which really increases the challenge. So here's where I introduce you to my little friend. This is my 5 domains of clinical sleep medicine. We can have problems with circadian misalignment. Remember I talked to you about sleep pressure and process C. Well, if we get out of whack trying to sleep when process C is not ready, you can have real problems. There can be pharmacologic influences that interfere with the ability to sleep, medical problems, environmental, psychiatric, psychosocial factors, and then finally we can't forget about primary sleep diagnoses. So some examples in outpatient medicine, you can get a delayed sleep phase syndrome for circadian misalignment. You can have pharmacologic factors such as insomnia due to drug or substance like too much caffeine or nicotine, or even hypersomnia due to drug or substance. People can be tired all day long because they require medicines that are sedating. Medical factors like chronic pain, psychosocial and psychiatric factors could be due to a primary mental diagnosis or even due to an environmental sleep disturbance like CPAP. And then primary sleep diagnoses can include the things you ordinarily associate with sleep medicine like obstructive sleep apnea, restless leg syndrome, and narcolepsy. And the rule of thumb is that by the time people come in complaining of a problem, they've usually got more than one. Okay, if you just stop at the first thing you think of, chances are you're going to miss the boat and you're not going to help this patient as much as you could. So let's go to the ICU. How can circadian misalignment disrupt sleep? Well, it turns out there's a lot of light sources that the patient may not need to be exposed to. This can suppress melatonin secretion and alter sleep phase. Daytime sleep is going to impair that sleep pressure that we learned about, promote nocturnal wakefulness, which is going to lead to circadian shift. So what can we do about that? Well, we can do our best to maximize environmental exposure to light during the morning and midday. We can encourage behavioral interventions to promote wakefulness during the day, such as positioning, early mobilization. I know there's a lot of talk about that in the ICU. And minimize environmental light during the nocturnal time frame. In terms of pharmacologic influences, there's a lot of drugs that we give in the hospital that are heavily disruptive of sleep. Pressors, beta agonists. Now, traditionally, pressors aren't supposed to cross the blood-brain barrier, but a lot of illnesses can alter that. Steroids, many antiarrhythmics are profoundly insomniogenic. Turns out that if a patient is being treated long-term with benzodiazepines in the outpatient world, if they are suddenly withdrawn from these medicines in the hospital, they can go into withdrawal. Opiates can suppress REM, they suppress slow-wave sleep, and they can promote nocturnal awakenings and can cause central apneas. So we know that benzos are significantly associated with delirium. We think that anticholinergics and opiates may be. Even at low doses, these might be at fault. So what can we do about these? Well, we have to know the patient's home regimen. If they're being treated with benzos in the outpatient world, we need to be ready and anticipate withdrawal syndromes. We should avoid the use of anticholinergics, benzos, or opiates as a management strategy for insomnia. Now, I know that the ICU world just was given a set of new guidelines in 2013 about sedation and delirium, and this is one of the main points, is that we should be thinking about using other drugs because of the potential harms. If we know we're giving a patient a sleep-disrupting medication, then for goodness sake, give the patient a break and dose that drug in the morning. And if the patient is having problems with insomnia, we can consider, quote, judicious use of a benzodiazepine receptor agonist such as zolpidem for the management of insomnia. Note that I'm not crossing over into how you're going to manage insomnia associated with delirium, because that's a whole different kettle of fish. What about medical conditions in the ICU? The top three are going to be pain. So pain, pain, pain. People in the ICU, particularly the SICU, but also in the medical ICU, are in pain. Other medical problems like cancer, sepsis, COPD, CHF are known to be associated with worse sleep quality. And so the potential solutions to this are that we really think about the nocturnal time frame, and we think about, are we managing this person's symptoms enough to allow them to get some sleep at night? This may mean that we think about their nocturnal pain control differently than their daytime pain control. There's a lot in this domain: noise, light, treatment-related environmental irritants, and fear and anxiety, and also delirium. So I'm going to talk about each of these in time. Noise. Obviously, the ICU can be a noisy place. Staff conversations, overhead pages, telephones, TV. The night staff has stuff they got to do, stuff they got to document. The morning team wants labs drawn. We've got to get x-ray rounds done. And these things can be a tremendous source of irritation to the patient. The EPA recommends a maximum noise volume of 45 decibels during the day and 35 decibels at night. And in the ICU, the peak noise can routinely exceed 80 decibels. Turns out PSG recordings in ICU patients that have been done attribute up to 25% of their awakenings and arousals due to noise. So this is a significant factor. And the obvious solution to this means coordinating your team efforts to try to take on this problem and do something about it. So it means that there are going to be quiet hours. We can reduce or eliminate overhead pages, and this requires a significant culture change. In one of the studies that I'll quote later, they actually had a traffic light that came up. In other words, if the noise got too loud, out in the nurse's station, it started blinking a light to remind people to kind of keep it down. One of those environmental things that may be of value. This is a snippet from a polysomnogram recording, and what you can see here, this is a noise level measured by a device that can track the number of decibels in the environment. Here's a noise spike right here, up to 70 decibels, and immediately following that, you can see the EEG frequency change consistent with an arousal. What about patient care? In one study, 40 to 60 interruptions each night were documented due to patient care activities. And there's lots of stuff we got to do. These are sick people, right? So there's vital signs, medications, phlebotomy, wound care, transportation, bathing, etc. And about 20% of all of these are going to result in sleep disruption. So we figure if we're waking up a patient 10 to 15 times a night due to the stuff that we're doing, that's enough to make you feel pretty crummy. So potential solutions usually involve thinking about the environment and rethinking the way we're delivering care. This is the one that requires coordination with the team, is consolidation. So rather than waking someone up 6 different times for vitals, labs, x-rays, we plan it all to happen kind of more or less in a coordinated fashion. light. If you shine a bright light on a person equal to about what sunlight is, it's going to disrupt sleep regardless of what it does to the circadian rhythm. Indoor light is about 180 lux, and we know that indoor light like this can actually suppress melatonin secretion. When you interview ICU survivors, they'll actually report light's less of a problem than noise. So obviously the solution here, I didn't put this on there, but the solution here is dark times. Keep the lights down, particularly if there are things going on, perhaps using area lights, making sure that external light from the street is blocked out, etc. Mechanically ventilated patients have a lot more sleep fragmentation, reduced sleep efficiency, and increased daytime sleep. Remember that chart that I showed you of the 24-hour cycle? All that sleep admixed with wake throughout the 24 hours was probably a mechanically ventilated patient. Contributing factors to this are going to include increased ventilator effort, abnormal gas exchange, vent desynchrony. These are obviously sicker people. They're probably more physically uncomfortable. So there is work that's evolving and that looks at the mode of ventilator delivery and sleep quality, but there's nothing conclusive and no recommendations have been made. But just as a point of interest, I quoted this study where proportional assist ventilation compared with pressure support improved patient ventilator synchrony, tidal volume, minute ventilation, and decreased arousals from sleep with increased amounts of REM and non-REM. So I guess it's worth paying attention to that there is evolving work going on about the mode of pressure delivery and how this might impact sleep. There was also increasing interest on using lighter stages of sedation during ventilation to allow natural sleep to happen. The myth that's very long-lasting is that we have to completely sedate people on mechanical ventilation, and there are those who are questioning this ethos to make sure that we're allowing patients the opportunity to have normal sleep so that it becomes easier to wake them up when we take them off the vent. Fear and anxiety is a big element in the ICU. They're in an unfamiliar environment. They may not be able to speak. They're really sick. They're not allowed to be around their loved ones, and they're having horribly painful things done to them, like A-lines and central lines, etc. Many of these people come to you with a diagnosis of generalized anxiety disorder. So again, understanding the patient's past before they had that wreck and ended up in the SICU may be helpful, because if this person is benzodependent because of their anxiety disorder, that's just going to be magnified by the time they get to the ICU. So potential solutions to this, we're going to look at their past medical history, recognize their prior diagnoses, and consider restart of their outpatient treatment if it's medically appropriate, and the non-pharmacologic, humanizing interventions that help people feel more calm, allowing them access to the family, soothing music, etc. This is something that most ICU teams are familiar with. This part may be a little bit off the beaten track for many of us. The idea of considering primary sleep diagnoses when the patient's in the ICU. People have obstructive sleep apnea, and most of them are not yet diagnosed. So you can ask yourself, man, why did that person have that single car accident anyway? Did they fall asleep behind the wheel? Is that why they're in my unit? Maybe they have another source of sleep disruption that has nothing to do with this stay, but then again, everything to do with this stay. Restless leg syndrome is also very common, more common in hospitalized patients because of blood loss. There's a relationship between restless legs and iron deficiency. So the potential solutions to this: know the patient's history, offer treatment for known primary sleep disorders if it's medically reasonable, and be vigilant. If the patient snores heavily, or there is evidence of excessive daytime sleepiness as an outpatient, this is the reason why they crashed up their car, think about getting them appropriately tested. Now this is from a recent study published in 2012, and this is going to show you just how difficult it is to study these things. Now this is done on hospitalized patients, not in the ICU, but they called it sleep rounds. And what they decided to do is they were going to measure several outcomes, including some surveys they gave to the patients about sleep quality. There's something called a Press-Ganey survey, which is done post-hospitalization to track hospital quality. It's a national survey. And they did noise recordings. And their interventions were called basic sleep rounds and deluxe sleep rounds. I'm going to tell you what those are in a minute. But you can see what they did is they had a baseline where they just measured these things. They had a time frame over a course of several months where they did basic sleep rounds. They did their washout period where they didn't do anything. And then they did their deluxe sleep rounds at the end. So we'll see what they came up with. Basic sleep rounds were that they had nursing staff and they had volunteers, medical students, who went around to each patient and they did sleep rounds. And what did they say? They had a checklist. And they said, good night, I'm a member of the sleep squad. I'm here to do your sleep rounds. It's now bedtime. And then they offered them all these things they could do. Would you like to go to the bathroom? Set the temperature so it's comfortable. You want a snack? Is your pain controlled? Can I get you a pillow? Can I turn off your lights, turn off the TV, draw the curtains? What else can I get you? I'm here to help. Okay, so they kind of systematized the idea that sleep's important to us. We want you to feel better. And meanwhile, back at the nurses' station, they had those traffic lights on for noise. And if the noise got above a certain level, the lights would blink and the nurses would keep it down. So they're really trying, and they're trying to see if this makes any bit of a difference. Now, deluxe sleep rounds, that's even better. They did the checklist, but they also said, can I get you a warm blanket? How about a cup of warm milk? How about a white noise making machine? Maybe a little hypoallergenic lotion or a room spritzer. So just making them feel like this is a little more of a human environment, seeing if these other things make a difference. And this is what they found. This is the sleep survey results. And you can see this is the baseline, basic sleep rounds, washout, and deluxe sleep rounds. And this is a busy slide, and I apologize for that. Really, the only point here is here. The only thing that came out as significant was on the washout time frame, how much difficulty did you have sleeping last night became worse. Now, there are lots of potential problems with this method that they use in that they had multiple things they were looking at. They really didn't have a hypothesis up front. And so finding one thing was statistically significant may not mean anything at all, but there was a trend toward the expected values. This is the Press-Ganey scores of the perception of noise during the different time frames. And higher scores on this means a more positive experience. So it means that the patient perceived there to be less interruptions due to noise. And what we can see here is this is kind of all over the map, but during the deluxe sleep rounds and during the basic sleep rounds, you can see that there's a general trend towards an improved patient perception regarding noise in the hospital, whereas during the washout period, it was below the national average for this survey. So to recap, the sleep-friendly ICU, sleep is a vital biological process. We take it for granted because it just happens for those of us where it happens in a healthy fashion. But sleep deprivation does have adverse physiologic consequences that have very real, meaningful endpoints. Interventions to improve the quality of sleep in the ICU requires a balancing act. These are competing goals. You can't leave someone alone and shut the door and turn the lights off if they're really, really sick. So high-intensity patient care is obviously going to disrupt sleep, and we want to be able to continue this while allowing for this. Any effort to improve sleep quality will necessarily involve a team approach. And proving improved outcomes, this is the challenge with respect to sleep. Because I hope I was able to engender to you how complicated it is to study. There's a lot of aspects to sleep, and getting the objective gold standard data, which is polysomnographic data, is extremely cumbersome. So I talked about the 5 domains of clinical sleep medicine. I talked about circadian misalignment and stuff we could do. Bright lights during the day, darkness at night. We can consider eye masks on the patient as one of those potential interventions. Behavioral interventions to promote daytime wakefulness, like positioning and early mobilization during the day. We talked about pharmacologic factors, avoidance of delirium by using benzos for anxiety, opiates for pain, not for insomnia, at the lowest effective dose. We're going to avoid anticholinergic drugs as hypnotics. I didn't point this out early on, but part of the elements of the ascending reticular activating system is the cholinergic system. We give someone an anticholinergic, we're making it hard for them to think straight. We're going to promote the process of delirium. Consider the use of a benzoreceptor agonist if a hypnotic is felt to be needed. And this is a strong underline to consider. We should dose insomniagens in the morning if possible. If we know we're giving the patient a sleep-disrupting drug, then give it in the morning. Give them a chance to get to sleep at night. And be vigilant for withdrawal syndromes, particularly for alcohol and benzodiazepines. Medical factors, think about pain control at night and protect their nighttime sleep. So help them with their sleep-disrupting pain, optimize medical management of insomnia-provoking medical problems, and we can consider judicious use of hypnotics for residual sleep disruption caused by medical problems under optimum management. For the environmental, psychosocial, and psychiatric factors, we can do our best to reduce noise during nocturnal hours, so televisions, conversations, non-essential monitoring equipment, noisy procedures, minimize those. We can give the patients earplugs or white noise machines. We can optimize patient ventilator synchrony to avoid that environmental influence on their sleep. And we can consolidate patient care activities whenever we can. And of course, anxiety in the ICU is important. Non-pharmacologic measures, there have even been trials that looked at massage therapy, guided relaxation, and music as potential non-pharmacologic forms of anxiety relief. If you need to address anxiety, use a low-dose benzo, but again, understanding benzodiazepines do carry a risk of delirium. And then finally, we're going to recognize and think about primary sleep diagnoses for our patients who have trouble sleeping. A lot of these people may come in with an undiagnosed case of obstructive sleep apnea or restless legs. So understand that there are some further questions you might want to ask. Continue management if they've got these problems as an outpatient. That's all I have for today. Anybody who's interested, I pulled a bunch of papers and references. These are some of them. I'm happy to share them with you. All you have to do is send me an email, and I'm happy to take questions at this point.
I apologize. I was unfortunately slated to give grand rounds to the radiology at the same time, so I walked in late. I noticed that in your slides that you had benzos and opiates, and as a new kid on the block from another place far, far away, we used exclusively benzos and opiates as our sedative drugs, as opposed to propofol and Precedex. And I was just curious about your opinion. You know, the teaching where I was that propofol really was more of a anesthetic, could be used in low doses to be sedative, but so what's your thought on, is there a difference? Does it make any difference? Are they basically all equivalent if you just dose them low enough?
So this crosses over a little bit into the idea of ICU sedation, which is a different kettle of fish than my background kind of prepares me to talk intelligently about. I did review some of those data and recommendations, and what I can say as a sleep specialist is that drugged sleep is not the same as natural sleep. So one of the things we should be thinking about is how we're going to give our patients the best opportunity to get natural sleep. The current recommendations that I read from 2013 really kind of disparaged the idea of opiates and benzos as the primary form of sedation in the ICU because there was a very bright line between benzos and delirium, a less bright line but a consideration for delirium associated with opiates, and the recommendation was to consider an agent like Precedex, which is a little bit shorter acting, doesn't tend to accumulate as much, and perhaps leads to a shorter duration of time to emerge. But again, it's beyond my comfort zone to talk about the ins and outs of sedation because that's not my field.
But from what you read, it looked like the Precedex might actually be a bit superior.
Yeah, and from a sleep medicine standpoint, you know, there are animal studies that look at propofol, and propofol does tend to assist with getting rid of some of that homeostatic sleep pressure. So propofol-induced sleep might be more similar to natural sleep than, say, benzo-induced sleep. Benzos have a lot of other problems too, like the sleep that you get from it is an ersatz copy of what real sleep is. It gives you mostly light stage sleep, it suppresses REM,
When you come off of it, you have all kinds of rebound phenomenon that happens, bad nightmares. And so it might be something that, those might be the mechanisms by which it contributes to the delirium that happen after emergence. So yeah, the trend is moving away from opiates and benzos, is my understanding.
That's great. Thank you very much. I really appreciate that.
Any other questions? Yes, sir.
No, in that one study where you had the 4 different interventions, the sleep team and all of that.
Sleep rounds.
The sleep rounds, yes. Did they looked at patient satisfaction. Has anybody ever looked at something similar in terms of outcomes?
Yes, the answer is yes. If y'all had the opportunity to see Nancy Collop from Emory come and speak about this, there was a more recent study that was published that did look at mortality, and unfortunately there was no difference. And I think it just speaks to the idea that this is really hard to measure, and once you get people involved in keeping the lights down, like what's the placebo, because they're going to try anyway. So it gets to be a kind of a difficult thing to get your hands around.
What's the physiology behind postprandial sleepiness?
Oh boy, that's great. So postprandial sleepiness. Well, I can go back. There's actually probably 2 contributors to that, 2 main contributors. One has to do with this. So the idea of process C. Towards the middle of the day, you see that the alerting signal is not quite as advanced as it could be. We've got a little lull here, and sleep pressure has been mounting the whole time. So this is siesta period here in this alertness level. And there are some cultures that have fully embraced that and decided that that's going to be their sleep time. So some of it has to do with the activity of the alerting systems, and the other side of it is what you choose to eat. So highly refined foods and carbohydrates, foods that are much more easily accessible, they create a hormonal response that is sleep-inducing. And there was a study that was done on rats where they fed them something they called the cafeteria diet. And I love this study because what they did is they took these rats and they gave them a calorically replete diet for a while, which means that they had enough calories to live, but it wasn't too much. And then they switched the rats to the cafeteria diet, which means, I presume, stuff that you could scoop with an ice cream scooper, like potatoes and noodles and stuff. So they gave them the cafeteria diet, which was calorically redundant, too many calories for what they were doing. And then they measured the rats' activity on an exercise wheel and how much they were doing stuff. It turns out the rats on the cafeteria diet spend much less time on the wheel, much more time quiescent, presumably sleeping. And that behavior persisted 3 days after they switched them back to the regular diet. So there's something metabolically different about eating a calorically redundant diet that has lots of refined, easily available calories. I actually think about that a lot when I'm talking to my patients who are too sleepy, because sleepiness as a symptom is nuanced, and it's got a lot of different moving parts. And if we're really beating our head against the wall trying to get a person to feel better, then I say, well, what are you eating during the day? Well, I'm going to McDonald's all the time. Well, let's look at that. Let's think about what you're doing and how this is contributing to your well-being. It's a great question.
But blood flow diverting from the brain to the GI tract is a myth.
I will not comment on that. I would have to look that one up. I think that's a little bit simplistic. Yes, sir.
That was a nice talk. I guess I'm one of the pet peeves of me is televisions in the hospital, which have become more frequent, more noisy, more blaring. And, many a times I'll be here in the middle of the night or early in the morning and TVs are blaring in the patient's rooms. The baby, who obviously is not watching TV in the ICU, has a blaring TV going on. And I even asked the administration if they could turn these down or turn them off at nighttime. And on the floor particularly, there might be a lights out time when they actually turn off the phones and turn off the TVs after a period of time to encourage even the floor patients to sleep and get a better cycle.
Yeah, I totally agree. The systemic approach to this is what's needed. You know, I think about this in lots of contexts. We're a hospital, we're a health promoting agency, and then you go to our cafeteria and you see what they're serving the patients' families. I mean, it's terrible, terrible stuff. We're a hospital, we're health promotional, and yet we've got these televisions on at night. We're not doing what we say we're supposed to be doing. So I agree, if it requires a policy that, it's nighttime, we're going to take the lights down and let everybody sleep. Sorry, if you want to watch TV, we're going to turn it off. Maybe that's what it takes. Yes, sir.
Along the same lines, though, do you see a use for the TV during the day as an awake or a mechanism of keeping people awake, keeping them from drowsing off during the day?
Yeah, sure, maybe. Yeah, interactions are probably better, but that's a good use for volunteers. Is you get people sitting up a little bit and have people come and talk to them and interact with them. That kind of gets a more humane wake-sleep cycle.
I mean, besides the Kardashians?
Besides the Kardashians. I don't know, that gets me riled up.
The solution that at least one institution had to the TVs blaring was the entire institution went to the volume control, and the speaker was on the patient's remote control cord, so that the TV in bed 1 was not being blasted to the patient sleeping in bed 2. It only came out of a thing that they could put next to their ear. That was it. So the family was not sitting around watching Judge Judy while the patient is, in agony with sleep deprivation. Anyway, it was one system's approach, but it actually wasn't bad.
That's what we have.
Yeah, but every time I walk in the room, those things are on Mach 6, and even you're halfway down the hall. My other complaints about that is they put TV in every waiting room. People often are sick and do not want to sit there and listen to that. And we're teaching people how not to read by looking at books, magazines, newspapers in waiting rooms. And try to get them to turn off the TV in the pediatric waiting clinic and put books and child-appropriate things out there. And they do some, but...
Well said. Dr. Wagner.
Yeah, well, I would like to see TVs removed from all waiting rooms, particularly TVs turned to Fox and everything. I have found that when you're sick, that reading really is not a real practical time passer, because you're too sick to concentrate. You don't have to concentrate much on TV because basically it's aimed at an IQ somewhere around 20.
All right, thank y'all for your attention.